This hearing will come to order. This is a fully virtual hearing, so I'm going to address some housekeeping matters. For today's meeting, the chair or the staff designee by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating background noise. Members are responsible for muting and unmuting themselves. If I notice that you have not unmuted yourself, I will ask you if you would like the staff to unmute you, but usually you hear me ask that and get yourselves unmuted. If you're still having problems, indicate by nodding, and the staff will then try to unmute your microphone. I remind all members and witnesses that the 5-minute clock still applies. If there's a technology issue, we will move to the next member until the issue is resolved, and you will retain the balance of your time. Please notice that there's a clock on your screen and will show how much time is remaining. At 1 minute remaining, the clock will turn yellow. At 30 seconds remaining, I will gently tap the gavel to remind members that their time is almost expired. When your time has expired, the clock will turn red and I will begin to recognize the next member. In terms of speaking order, we will follow the order set forward in the rules of the House, beginning with the chair and the ranking member, then members present at the time the hearing is called to order, and then you'll be recognized in your order of seniority. And finally, members not present at the time of the hearing is also called to order will be recognized as they appear. Finally, House rules require me to remind you that we have set up an email address to which members can send anything they wish to submit in writing to any of our hearings or markups. The email address has been provided to your staff in advance. So today, the subcommittee will receive testimony on fiscal year 2023 defense health appropriations and medical readiness budget requests. We have 5 witnesses. Ms. Mullen, Acting Secretary of Defense for Health Affairs, Lieutenant General Place, Director of Defense Health Agency, Lieutenant General Dingle, a Surgeon General of the Army, Rear Admiral Bruce Gillum, a Surgeon General of the Navy, and Lieutenant General Miller, Surgeon General of the Air Force and Space Force. We are looking at some new faces on our distinguished panel, and we want to thank you all for appearing here today, and we look forward to hearing from each one of you. The President's budget request for fiscal 2023 continues the significant transformation of our health military systems. As appropriators, we are concerned about what some of these reforms will ultimately cost in terms of dollars and loss of medical capacity and time. These capabilities, once lost, cannot grow back overnight, if they can even return at all. The health military system is unique in its roles and its responsibilities. The committee remains focused on ensuring the reforms do not prescribe less than optimal military health systems for our service members and their families. In particular, questions remain on planned reductions to military medical manpower and the impact this will have across the military healthcare system. We understand the difficult balance that the military departments are trying to come to terms with. We'll want to hear from the services on planned reductions and the Defense Health Agency on plan to mitigate risk to beneficiaries and service members. The survivability of our service members in future conflicts will depend upon how successful our military is in planning, programming, and budgeting for the right mix of medical military personnel. We do not have a time to get the solution set wrong. Lives depend upon it. We have to get it right and make sure it's right the first time. We must give thoughtful attention to the potential unintended consequences of these reforms, from medical research to military readiness and beneficiary care. If the assumptions prove wrong, and we've already divested the capabilities, it could take us decades and billions of dollars to rebuild. And in the meantime, patient care will suffer. On medical research, we understand that the department is preparing a major organizational shift of medical research from the Army to the Health Defense Agency starting in fiscal year 2023. We want to hear more about those plans. We have the services surgeon generals before us to discuss their priorities for medical readiness within each of their military departments. In particular, We will want to hear how mental health is being prioritized, especially in light of the tragic suicides on the USS George Washington. We must better understand what the services are doing to ensure our service members and their families have the support that they need to do the extraordinary jobs we ask of them. The last few years of the COVID pandemic have been difficult for our healthcare medical providers, and they have strained our military healthcare system. I want to thank each of you and the dedicated medical personnel that you serve with for deploying community vaccination centers across the country in support of FEMA and the national response to COVID. Much appreciated from my constituents here in Minnesota, and I know all across our nation. So I'm going to ask you to present your summarized statements in a moment, but first I'd like to recognize our distinguished ranking member from a very sunny state. You might hear the rain falling behind me in background, but Mr. Calvert, will you please give us any of your opening comments?
Well, thank you, Chair McCollum, and I, quite frankly, I'm envious of your rain. I wish we had some here in California. And thank you to our distinguished panel for appearing before us today. The Defense Health Enterprise plays a critical role in ensuring the readiness of the force. But as we've seen over the last 2 years, it's also an integral part of our nation's crisis response. As such, it's important that we adequately resource this important endeavor. Unfortunately, the President's fiscal year 2023 budget request fails to do that. In fact, it cuts the Defense Health Program budget from the fiscal year 2022 enacted levels. That cut is even deeper than it appears when you consider the discrepancy between the current rate of inflation and the estimate used by the department in building this budget. One of the major assumptions in cutting this budget is that COVID requirements are, according to the budget request, expected to decrease as we transition to COVID becoming endemic. I'll be interested in hearing more from you about this assumption. I also want to hear your views on whether you think this budget provides sufficient funds for mental health care. As you know, the military continues to have an unacceptably high rate of suicide. Master Chief Petty Officer of the Navy, Russell Smith, testified to our colleagues recently that it takes Navy sailors an average of 5 weeks to get a mental health appointment. That's unconscionable, and I'll be interested in your views on how we can fix that. Finally, the military health system is undergoing significant structural changes and shifts in roles and responsibilities between the Defense Health Agency and the services. I'll be interested in an update on these ongoing changes. So thank you, and I look forward to your testimony. And with that, Madam Chair, I yield back.
Thank you. Your full written statements to the testifiers before us, they're going to be placed on the record, and members have had copies made available to them. And I would like to leave as much time as I have for members to ask questions. So I would like to encourage each of you to summarize your statement, to be complete, and then be succinct in responding to questions. So we would like to start out with the Acting Secretary of Defense, Mullen, first. We'll hear from you first. Ms. Mullen.
Thank you. Chairman McCollum, Ranking Member, distinguished members of the Subcommittee, I'm pleased to represent the Office of the Secretary of Defense to discuss the Defense Health Program and its contributions to health and medical readiness of the department. Before I begin, I want to acknowledge the tragic events that occurred in Uvalde yesterday. 2 of the victims are being treated at Brooke Army Medical Center, and this is a reminder of the extraordinary care that the military health system can provide when called upon, none of which is possible without the support of this committee. Our hearts go out to the victims and their families. In my testimony, outlining the major activities unfolding in the military health system that inform our budget proposal for FY23, as well as briefly discuss issues affecting FY22 execution. The past year witnessed significant advance in our response to the COVID-19 pandemic, both within the department as well as the department's support to civilian authorities. Lieutenant General Place will provide further details on our COVID response and preparedness for the future. The National Defense Authorization Act of FY27 enacted sweeping reforms to the organization and management of military medicine. We've made significant progress in implementing these reforms. Today, DHA exercises authority, direction, and control of all MTFs worldwide. The same law directed DoD to restructure or realign MTFs as appropriate to support the department's readiness requirements. Restructuring efforts were paused on April 2nd, 2020, as a result of the resources required to respond to the COVID-19 pandemic. We plan to restart implementation beginning in the first quarter of FY23 with targeted completion by September 26. The department's mission requirements in supporting our national COVID response, however, have adversely affected the Defense Health Program budget execution in FY22. Private sector care costs have increased as military medical staff are deployed to support civilian missions, as well as other military medical personnel vacancies increased in MTS. At this point in the fiscal year, DHP private sector care projections are still uncertain, both due to the trajectory of COVID-19 costs and the uncertainty regarding return of suppressed non-COVID-19 care. Despite these short-term budgetary challenges, the MHS continues its decade-long track record in responsibly managing healthcare costs, which remain below the national health expenditure per capita rate. The department is grateful for the long-term advocacy and support from this committee for our military medical research program in those areas of most pressing need and relevance to today's emerging threats, which include the COVID-19 pandemic. In order to prepare for future pandemics, our future budget will support pandemic readiness and response in the MHS by enhancing capabilities to conduct rapid research and medical countermeasurement development, such as diagnostics, treatments, and vaccines, while strengthening the capability of the department to quickly identify and characterize new variants and other emerging biological threats. I thank you for, in closing, I want to reaffirm this budget's commitment to the Secretary's 3 priorities: defending the nation, taking care of our people, succeeding through teamwork. These are our no-fail missions. Current events outside the department's control may test us, but our force is only as strong as its people. Respect for every single person who volunteers to serve this country in the armed forces and taking care of them and their families is core to what we do. Thank you for inviting me to speak with you. I look forward to answering your questions.
Thank you so much. We'll next hear from Lieutenant General Dingle.
Chairwoman McCollum, Ranking Member Calvert, and distinguished members of the subcommittee, thank you for the opportunity to speak to you on behalf of the Army soldiers, civilians, and their families about the Defense Health Program. As the 45th Army Surgeon General, my promise to you, our soldiers and family members, is that we will remain good stewards of the appropriations and will always be ready to answer our nation's call. Today, our Army's medical force is ready to deploy today, fight tonight, and return them to duty tomorrow as we provide world-class health care to over 147,000 forward deployed U.S. Army soldiers around the globe. The Army's ready medical force will provide evolving health care to meet the demands of the warfighter in any operational environment. My strategy to provide a trained and ready medical force consists of 5 objectives. We will synchronize and integrate the medical effort within the Army, the Defense Health Agency, the Joint Staff, and combatant commands to ensure responsiveness and relevancy to execute the National Defense Strategy. We will build readiness through investments in our human capital. People are first. We're grateful to Congress for the authority to increase health professional officer special pay caps. Our healthcare professionals have demonstrated their dedication and readiness in response to the global pandemic for the last 2 years. We must be innovative and judicious to remain competitive with national healthcare industries to recruit and retain our best professionals. We must monitor the impacts of the prolonged pandemic response on our healthcare workforce, our soldiers, and family members. We must also mitigate the suicide and stress issues, for they harm our most valuable resources, our people. One suicide is too many, and we'll continue to combat it at every level. We will modernize the medical force. Modernization is occurring in near term as Army Aviation expands future vertical lift and future long-range assault aircraft. In parallel, we are developing a medical variant. Army medicine will not be left behind. We will medically reform. We're transforming in accordance with legislation and the department guidelines. As demonstrated by the fiscal year 2023 presidential budget request, the Army has completed or programmed resource transfers of more than $22 billion of the DHP and over 32,000 civilians to the Defense Health Agency. Further, the fiscal year 2023 presidential budget includes transfer of resources from medical research and public health organizations to the DHA and DHP. Focused on readiness, our regional health commands will be renamed Medical Readiness Commands this fall. Finally, we will strengthen alliances and partnerships. I have reestablished liaison roles in support of our NATO and partner medical groups. The cohesion ensures combined forces medical readiness in a globally integrated environment. In closing, I want to thank the subcommittee for your longstanding support to the Army and Army medicine. Our trained and ready medical force depends on timely, adequate, predictable, and sustainable funding. With your continued support, Army medicine from the foxhole to the fixed facility will in fact remain trained and ready. Army medicine is Army strong. I look forward to the subcommittee's questions.
Thank you. Rear Admiral Gillum, would you please go ahead with your statement?
Thank you, Chairwoman McCollum, Ranking Member Calvert, members of the committee. I'm pleased to be with you today to provide an update on Navy medicine. On behalf of our mission-ready One Navy Medicine team, please know that we are grateful for your support as well as the trust and confidence you place in us. Navy medicine is best described as well-trained people working as expeditionary medical experts on optimized platforms, demonstrating high reliability performance as cohesive teams, projecting medical power in support of naval superiority. These priorities guide our deliberate planning, resource allocation decisions, and strategic program investments. Consistent with the Chief of Naval Operations' emphasis on get real, get better, I continue to reinforce that rigorous self-assessment and rapid cycle feedback remain important considerations of our efforts to objectively evaluate our performance and establish high reliability throughout Navy medicine. In my written statement, I provide you more details about our efforts in many key areas. However, in the interest of time, I will highlight three significant lines of effort: COVID-19, operational capabilities and requirements, and mental health. In response to the COVID-19 pandemic, our highest priority remains protecting the health of sailors, Marines, and families, while maintaining readiness and operational effectiveness of the naval forces. The most effective and advantageous public health preventive measure is vaccination, our biologic body armor. Demonstrating personal commitment and unit responsibility, sailors and Marines have responded with approximately 97% of active naval forces fully immunized. Throughout the pandemic, naval personnel have shown responsibility, resiliency, and toughness in helping to protect their shipmates, installations, and communities from COVID-19. And as you mentioned, we also rendered medical assistance to our fellow citizens. The operational tempo of our response teams over the last 2 years remained consistently high as we deployed to 28 cities to support civilian medical facilities. There is now no doubt that these efforts made a difference in the lives of our fellow citizens while sharpening the skills of our teams, which they will use when they deploy outside the United States. To this point, Navy's hospital ship USNS Mercy is currently deployed in support of Pacific Partnership 2022, the largest multinational humanitarian assistance and disaster relief preparedness mission conducted in the Indo-Pacific. We expect a lot of our Navy medical personnel, and we recognize that we must provide them with the operational capabilities, including responsive and flexible platforms and equipment sets that allow them to execute their demanding responsibilities. To meet the challenges of providing force health protection and saving lives at sea, we're adapting our Naval Expeditionary Health Service support capabilities in alignment with the challenges of distributed maritime operations and expeditionary advanced basing operations. We are grateful to this committee's continuing support of our requirements. A key priority for us is ensuring our sailors and Marines have access to the mental health services they need. This includes placing more providers forward and embedded in operational platforms. We currently have 36% of our mental health providers serving Navy and Marine Corps personnel in operational and training commands, effectively positioning the access to care where it might be needed most. All of us recognize that every death by suicide is a tragedy, with devastating effects on families, shipmates, and commands. Suicide prevention is an all-hands responsibility. It requires ongoing work to promote health, build resiliency, and develop a sense of community. In summary, Navy Medicine's center of gravity is our commitment to provide expeditionary maritime medical care to our forward deployed naval and joint forces. The ability to quickly deploy and support a crisis response around the world makes military medicine unique, but more importantly, demands that we are both operationally relevant and clinically prepared to save lives at sea and at shore. Again, thank you for your time, and I look forward to your questions.
Thank you so much. And Lieutenant General Place, I went out of place, no pun intended on your name, I'm sure you had that before, and I did not mean to skip over you. Would you please go next?
Chair McCollum, thanks. And Ranking Member Calvert, distinguished members of the subcommittee, thank you for inviting me today to join Ms. Mullen and the Service Surgeons General to discuss the Defense Health Program. I'll briefly focus on some of the critical responsibilities of the Defense Health Agency. Response to the COVID-19 pandemic was one of our top priorities, vital to the medical readiness of our forces and the health and well-being of all Americans. We've conducted over 6.5 million COVID tests worldwide. In February of this year, we also enabled military medical treatment facilities to distribute hundreds of thousands of over-the-counter antigen tests to eligible beneficiaries at no cost. The Defense Health Agency is regularly updating our COVID-19 practice management guidelines. We're currently on version number 8 to provide military clinicians worldwide a single document on best practices, the latest evidence, and guidance across all clinical specialties. The Defense Health Agency led a comprehensive campaign to administer COVID-19 vaccines. As of May 18th of this year, the military health system had administered almost 8.3 million doses of COVID-19 vaccines, and more than 1.7 million military uniformed personnel have been fully vaccinated. Throughout this pandemic, the DoD provided extensive support to FEMA for COVID-19 responses that include both mass vaccination and healthcare delivery augmentation in communities needing additional personnel resources, as you indicated. We also delivered medical support to the Department of State and Homeland Security for assisting evacuees from Afghanistan. Our medical teams were proud to contribute to this whole of government response for both events. In non-COVID activities, the department continued to proceed with a multi-year implementation of our new electronic health record, MHS Genesis. Today, MHS Genesis has been deployed at 53 military medical treatment facilities and at more than 1,300 individual locations with more than 77,000 active DoD users. We're currently on schedule to complete the deployment by the end of calendar year 2023. The DHA also manages the TRICARE program. Among the most important strategies we pursue is the development of effective TRICARE contracts that deliver high-value, patient-centric care that integrates military and private sector care. T5 contracts represent the next generation of these contracts. The DHA issued the T5 request for proposals in 2021 and is now evaluating those proposals with our intention of announcing awards by the end of this calendar year. Ms. Mullen noted our current budgetary status and future plans. I'll add that the military health system is not unique in the year-to-year variability associated with predicting healthcare costs. COVID-19 has only exacerbated these challenges. Nonetheless, we remain vigilant about our medical expenditures, and we appreciate that Congress continues to grant the department carryover authority, allowing the DoD to maintain better funding flows to minimize disruption of healthcare services to our beneficiaries. Again, I'm grateful for the opportunity to represent the men and women of the Defense Health Agency, and I thank you for inviting me to speak with you today, and I look forward to your questions.
Thank you so much. Lieutenant General Miller, if you could wrap this up for us, and then we'll start with questions. Thank you so much for being here.
Thank you, ma'am. Good morning, Chair McCollum, Ranking Member Calvert, and distinguished members of the subcommittee. It is an honor to appear before you today as a Surgeon General of the Air Force and Space Force to discuss the Air Force Medical Service and my vision and priorities. I appreciate the committee's longstanding support to the AFMS and the department. I want to take the opportunity to recognize and thank the outstanding professionals of the Air Force Medical Service. Since its creation in 1949, the AFMS has provided leadership in aerospace medicine developments, aeromedical evacuation capabilities, emerging military operations, and recently, the U.S. COVID-19 response efforts. The AFMS team has and will continue to serve the nation as we fly, fight, and win. The air and space forces are inextricably linked in defense of our nation. The AFMS provides ready medics to ensure airmen and guardians are medically ready to defend the nation. In the past year, we faced unprecedented challenges from responding to the COVID-19 pandemic to finalizing the transition of Air Force military medical treatment facilities to the Defense Health Agency. Currently, more than 80% of uniformed AFMS medics work and train in military medical facilities, which serve as one of our key readiness training platforms. The AFMS, more than ever, must be bold, resilient, and above all else, ready for a fight tonight, tomorrow, and beyond. Our vision is to ensure we are the world's elite medical service in air and space. The reality we know is the future fight will not be like what we have seen in the past. We need your support to evolve now to modernize our key readiness capabilities, properly equip our medics, and ensure the Air Force and Space Force remain ready fighting forces. In future conflicts, we cannot assume we will have the upper hand. Advances in our understanding of human biology, digitization, communications, and artificial intelligence will enable Air Force medics to accelerate change and win. Included in this testimony is the AFMS strategy map. I'll briefly outline my priorities. First, generate high-performing airmen and guardians by prioritizing training, maximizing medical availability, and optimizing human performance. Second, enhance joint and combatant commander capabilities by increasing the agility of patient movement, improving the medical supply chain, and increasing global health engagements. And third, maximize human capital and strategic resources by breaking down barriers of inequity, incorporating policies focused on diversity and inclusion, and equipping airmen to evolve for tomorrow's fight. The AFMS is reimagining the design and future of our readiness capabilities, such as air medical evacuation and critical care air transport teams. We're exploring and challenging our previous decisions about the size and types of clinical teams and how to best train and sustain their skills. We are actively evaluating how our medics can remain agile and leverage technology to provide trusted care anytime, anywhere. To respect the committee's time, I've submitted my remaining comments into the written record. Thank you for this opportunity, your continued support, and I look forward to answering your questions.
Thank you so much, Lieutenant General Miller. I want to thank all of you for your testimony, but before we go to questions, I don't know who's doing your technical. On a few occasions, the mic has cut in and out, so that might be something on your side you want to take a look with your microphone. And members, if when you're asking a question or something like that, you don't hear everything because of it cutting in and out, please let us know. We'll make sure you get everything you want on the record. We'll now begin questions, and I'm going to direct my questions to specific witnesses, and I would encourage my colleagues to do the same, who they want to hear from. An order of recognition is now being placed in the Zoom chat. Hopefully it matches what I've been emailed, and members should know their place in line. Right now I'm going to recognize myself for the first question. When the Military Medical Reform Act was introduced in 2017 and the National Defense Reauthorization Act, there were assumptions that were made about efficiencies and future cost savings would be gained. These assumptions also were made about what the private sector was going to be able to do. The department, with the rest of our country, has seen the private sector medical costs continue to grow. And we're also seeing shortage of medical expertise in some areas. The pandemic exposed weaknesses in the private sector capacity. And we have concerns that some of these reforms are going to be too far in the direction that they're going. So my first question is going to be on the cost savings. So Ms. Mullen, what is the basic line that the department is using, a point of comparison to determine how the reforms impact both the bottom line of the Defense Health Program? So essentially, 5 or 10 years from now, how do we look back on this effort, and how do we actually measure cost savings so that we have a common understanding at what point in time will we be using to measure for a measuring stick? And cost savings also with not having quality be deterred in any way, but maybe even quality enhanced with these cost savings. My second question is on the analysis that's been done to inform the department's implementation of these reforms. For example, the 619 report was submitted to Congress last August. It was detailed in the descriptions of manpower reductions that the services wanted to take, but gave very little in assurances that beneficiary care would not be adversely impacted. So as you can see, I'm not only interested in what we were going to maybe see for cost savings, but quality and timely of care for our beneficiaries and the survivability of our men and women in conflict as well. So we need to be thinking ahead about our public medical system and mental health system 5 or 10 years from now. We know that there's a shortage of providers. Our public health system relies on practitioners being produced by the medical health system. So General Placer, Ms. Mullen, can you describe the consultations that are going on with the American Medical Association on their gaps in our public health system?
Thank you for the question. A lot of that was cutting in and out, so I will try to attempt to answer the questions I believe that you asked.
Okay.
I believe the first part was about the budget. As I mentioned in my opening remarks, the last 10 years, the budget has grown at a lower rate than NHE. And in FY22, COVID-19 costs have tracked about $669 million through March and projecting about $1.9 billion for FY22, which includes deployment support for FEMA. FY23 budget, it is going to be lower for the COVID projected costs, and that is going to be, and that does include testing, surveillance, variant identification, and PPE. As for the, medical manpower reductions, as you know, we are in a current, congressionally mandated pause on those, on the cuts. The military medical manpower cuts are clearly, of concern to Chairman Milley. And the military departments are responsible for sizing, and we respond to those requirements. We plan on, backfilling those cuts with civilians, our managed care support contract network partners, and contracting staff. I think that gets to the bulk of your question, but I'm not quite certain.
Well, it does, but it still doesn't answer it. So are you really looking, bottom line, are you really looking at the shortage of certain medical professions in the private sector? And in some of the areas, particularly where some of the beneficiaries would be receiving their care. Because if we're taking from the private sector, we're only making the private sector worse and then creating an even bigger problem for some of our beneficiaries. And I know Mr. Kilmer is going to have some follow up on this. He's our bird dog on this. So if I just want to know, what are you looking at? How are you doing this? Are you talking to the medical association, the nurses association, PAs, occupational therapists, the whole gambit? What's been the dialogue you've been having, and how are you tracking this regionally?
Regarding the recruiting and retention of military mental health providers, we are working on a behavioral health staffing model to match supply with demand, which we believe will be finalized this summer. We intend to implement a pilot this fall in 2022 to synchronize effort with the military assignment cycle. We are adding psychiatric PAs, nurse practitioners, licensed mental health counselors, professional counselors, family and marriage therapists, and we are also significantly increase our telebehavioral health, including 63,500 visits this year. We are also trying to lower the referral and approval TRICARE barriers. And as you know, while there are shortage in certain areas, we are tackling them, and we understand that this will not be an easy or a quick fix.
Well, I thank you for that. I think I'm going to be submitting some more detailed questions on that for the record and not taking up any more of my colleagues' time. Mr. Calvert?
Thank you, Chair. Chair brought up mental health, Ms. Mullen, and I'd like to ask a question both to you and to the Lieutenant General. Either you please feel free to respond to this. As noted in my remarks, we have a problem with suicide in the military. One of the ways we can try to remedy that is through access to mental health care. But the wait times for appointments have been way too long. As you know, the TRICARE ceiling of 28 days is just too high. As you prepare the requirements for the new TRICARE contract that's due out this fall, are you considering reducing the maximum mental health care access wait times below the 28 days in the current contract? And the other service generals could also answer that question.
I'll start first and then I'll turn it to General Place. As the Secretary has said, one death by suicide is one too many. The department is taking a comprehensive public health approach to suicide prevention. As I've mentioned, we not only we increased telehealth, we've also increased screenings, and we're working closely with the VA in developing clinical guidelines. As you know, most MTFs actually do meet the CARE standards. However, each month, 1 or 2 MTFs are out of compliance. But the average across the system is 13 days for an initial and 18 days to a follow-up, which cases requiring immediate care being seen absolutely immediately. And the managed care support contract requirements are not something that I am familiar with in the T5 right now.
General?
Yes, sir, if I could. You mentioned the standard for behavioral health is as a specialty care. That's based in conversation with subject matter experts in the civilian community. As Ms. Mullen already indicated, in general, the timeline, the average timeline varies somewhere between 11 and 13 days for an initial behavioral health evaluation. And then follow-on appointments are based on the individual person, the care requirements of them. The variability is certainly there, in particular in some of our remote locations. In order to address that, we are leveraging all kinds of capabilities to include telebehavioral health and sinking significant investments, both from our own facilities as well as contracting with other behavioral health facilities that offer telebehavioral health, both for our service members and their families here in the United States, as well as those in OCONUS locations that it may be more difficult to find behavioral health capability.
And then Representative Calvert, one thing that I will add is in the Army, we are also working in conjunction with the DHA to those locations where it's hard to hire in those remote areas. I'm leveraging and shifting uniformed personnel to go to those locations to fill those gaps to help with the workload in those areas. And we'll continue to work with DHA to surge, Compo 2, Compo 3 in active duty uniformed personnel to assist with the behavioral health workloads also.
And Ranking Member Calvert, from the Air Force standpoint, we appreciate that really 2 key ways to increase access is filling in manpower where there's gaps. So we are working with the DHA to consider privileging of specialists such as licensed professional counselors, licensed marriage family therapists, if we are having challenges finding psychologists, social worker, or other mental health workers in certain locations that might be a little more remote. Another way to address access is something we call a targeted care model, where we are looking at ensuring that patients are getting to the right care at the right time. And the question is, does everyone need to be seen at the MTF in mental health? Or through a triage process, would some be better served in other means, working through chaplains, working through marriage, family, life counselors, in addition to the potential for group appointments? It's a pilot that's been ongoing, it's been very successful, and it has increased access for those patients in highest need that need to get to mental health, and that will continue within the AFMS.
Yes, and Ranking Member Calvert, I would just add, like all of my colleagues, we also focus on the prevention side. So beginning in boot camp, all of our recruits are taught stress reduction and meditation techniques. We're teaching the junior leaders, the enlisted personnel, as well as the chief's mess and the line officers, how to identify those at risk so that we can get them to care. But really building on the CNO's Culture of Excellence initiative to really try to develop toughness and resilience at the front end.
Well, this obviously is a concern to all of us. We see a rise for a number of reasons, and not just in the military, throughout our society. I think in mental illness and dealing with suicide. So I hope that all of you focus on that and try to potentially bring us some solutions. If we can help fund that in any way, I'm certain it will be a priority both to myself and to the chairman. Thank you. Yield back.
Thank you. Well said. And could you please provide us the standard for licensing? I worked on this issue for licensing, especially for family and marriage counseling. And it's different in different states, and we should be going for the highest standard and not just what a state standard is on there. So if you could get to me your mental health standards. I know we train our chaplains well, but states, as you are very aware, could be very different. So if you could get to the committee, I think the ranking member and I want to make sure that our people are getting the very best when it comes to counseling. Next, we'll hear from Mr. Thank you, Mr. Rufenberger, and then Mr. Carter.
Okay, thank you, Madam Chairman. First, I want to thank each of you for being here. I look forward to your testimonies today and how the DoD plans to better mental health services and medical readiness for our military service members. I tell this story frequently, but since it's so important to why I ran for and continue to run for office, I thought I would let the panel know about the importance of trauma care and trauma research. My life was saved at the University of Maryland Shock Trauma, considered one of the top trauma centers in the world. I personally had Army leaders from General Dingell's team up to Shock Trauma to learn about the important breakthrough they are doing there and the unique insights they have at a trauma center for both our military and our population. Then my question is, Ms. Mullen or General Place, how would you assess the current capabilities we have in trauma care, both on the front lines and for our service members who access treatment facilities? What adaptations or investments are you looking to make in the FY23 budget to improve reliable and effective trauma care or access to it? And how are you leveraging private healthcare systems or university-based research centers like the University of Maryland Shock Trauma Center? And how is the department continuing to invest in the Uniformed Services University for the Health Services so they are able to ensure military readiness, especially when it comes to trauma care? Either Ms. Mullen or General Place.
Yes, sir. Ron Place here, if I could. So when it comes to the trauma care itself, the department continues to expand the number of medical centers that are trauma centers. Only one level 1 trauma center, and that's Brooke Army Medical Center in San Antonio, but the number of level 2 and level 3 trauma centers continues to expand. When it comes to the financing part of it, we're not very good at billing for care, but significant efforts in concert with members of Congress and state legislatures for Medicaid capabilities and uninsured capabilities, the funding flows that we're receiving and the ability to partner with states for those Medicaid and uninsured continues to increase, which makes it doable for us. Now, you specifically mentioned shock trauma. As you're very well aware, shock trauma is one of the organizations that the Department of Defense, specifically the Department of the Air Force, has had a relationship with for years. We continue to leverage that relationship, but each of the military departments continues to evaluate their individual relationships with level 1 trauma centers to leverage to the greatest degree possible those areas that most closely mimic the types of trauma that we see in combat to leverage what they see. And then finally, you mentioned research. Yes, the Uniformed Services University does a good job of that. But across all 3 of the military departments and within the Defense Health Agency, whether it's clinical research, bench research, pharmacological research, all of it goes through the Joint Trauma Center and the Joint Trauma Working Group, Education and Training Working Group, to leverage the most critical research capabilities using cooperative research and development agreements or internal research to further our understanding and capabilities within trauma. I don't think we're perfect, but iteratively, we're making great progress each and every day.
Is that level of communication between the DOD and trauma center like University of Maryland Shock Trauma and other centers, is it a good communication relationship, and are both sides benefiting from that relationship?
Yes, sir. Both sides are benefiting, and the relationship is really through the NDMS, the National Disaster Medical System. We leverage it, we get it better every day, but relationship is very good, sir.
Okay, I yield back.
Thank you. Mr. Carter and then Mr. Kilmer.
Well, I want to thank all of our guests for being here, and I thank you for talking about something that's really important. We want to make sure that our warriors and our beneficiaries have proper care. And the mitigation efforts require hiring civilian contractors to fill medical billets. We are eliminating 18,000 billets, and that's a lot of folks. We need to decide. I need to know from Secretary Mullen and Lieutenant General Place. We have little confidence that beneficiary care will not be negatively impacted by the reduction in medical billets based on reports that have been submitted. What factors are you looking at to suggest that DHA can recruit the number of civilian practitioners needed to mitigate potential access to our care for beneficiaries? What is the average amount of time it'll take to hire civilian medical professionals?
Sir, if I could, General Place here. So the department tasked the Defense Health Agency to develop a plan for how to accomplish both the potential reduction of uniformed medical practitioners, as well as the potential right-sizing or scoping of 36 different military medical treatment facilities. That plan is a comprehensive plan. I don't believe it has left the department yet. Certainly none of it will be done until it gets to the Congress. In fact, none of it will be done until 6 months after it gets to the Congress. But we look at what's available in the community, and we look at what's the quality available in the community, and then have developed significant interactions with the managed care support contractors, the local physicians' offices, and the local hospitals on what's within the realm of the possible in each and every one of those installations. And then depending on how it actually works, because no plan survives first contact, we've all learned that as military officers. So as it starts to be developed, if it ends up going in a direction differently than what we planned, the department has given us the authority from a conditions-based requirement to change, modify, or even potentially stop the transition in some particular community or some particular area. Again, that very detailed plan will be coming to you likely this summer, I think, but we won't action any of it until that plan comes to you.
Well, part of that plan is determined is about the survivability of our warriors. And if we want to have a more lethal force, how can you balance that with survivability in any one of the major military conflicts that we may need to be ready for? Looking at medical requirements from the tip of the spear, are you concerned that with the reductions each of your services planning to take over the next 5 years, those reductions will make survivability more difficult? Why or why not? We got great.
Sir, I'm not sure exactly who you're asking that question for. I'll start only to say that we all work together on it. But the most important responsibility the secretaries of the military departments have is to mitigate all risk to all parts of the mission, to include the medical support part of the mission in their force shaping requirements. So the communication from the service surgeons general and my team happens on a daily basis, on an iterative basis, to balance what those requirements are. We share your concern for America's sons and daughters in combat, but it's not just healthcare. It's protective equipment. It's the lethality of the armaments that they have. It's the public health services that we provide to them. It's all of everything. And our healthcare team is just one part of that risk that our senior military department leaders must work through.
And Representative Carter, what we've done in the Army as we work, again, not in a silo, but as a team with the DHA, initially, we were reducing 6,900 plus billets in the Army. After that look, and we did exactly what you talked about, done the assessment, synchronized with the Defense Health Agency, and the Chief of Staff of the Army, General McConville, basically said, no, we must take care of our people and we cannot reduce 6,900. And so our number is 2,900 now, where those 2,900 billets are not impacting any specialties or providers or healthcare capability. At the same time, what General McConville has done for the Army, we've done a bottoms-up review from the war fighters, looking at our medical operational force and what are those requirements. And so as we go through the TAA, or the Total Army Analysis process, some of those billets will be coming to the medical operational side of the house. The 2,900 billets are from my command, the medical command, which support our medical treatment facilities. But we're looking from the foxhole to the fixed facility to try to ensure that it's a trained and ready medical force to save the lives that you talked about.
Well, thank you, General, and I appreciate your answer.
Thank you. Mr. Kilmer and then Mr. Diaz-Balart.
Thanks, Madam Chair, and thanks to each of you for being with us today. General Place, as you know, Naval Hospital Bremerton in my neck of the woods in recent years has closed both its emergency department and more recently the labor and delivery unit.
Mr. Kilmer, you cut out. Please repeat, and we won't hold it against your time.
Okay, my question's for General Place. Naval Hospital Bremerton in my neck of the woods in recent years has closed both its emergency department and labor and delivery unit. General, I was assured by your office that these closures were based on a thorough market analysis, which confirmed that surrounding hospitals, including St. Michael's in Silverdale and Madigan, had the capacity to provide care for the folks impacted by this closure. The Defense Health Agency also assured me that vacancies could be filled by hiring medical professionals in the community. But despite these assurances, St. Michael's recently voiced serious concerns about absorbing additional patients and their ability to hire medical professionals to fill growing vacancies. Madigan expressed similar concerns, particularly around hiring. And these difficulties seriously undermine DHA's market analysis. This should not come as a surprise, given that even before the pandemic, the Department of Health and Human Services identified Kitsap County, where Naval Hospital Bremerton is, as a geographic health professional shortage area and a medically underserved area. So I'm concerned about these closures, and so are my constituents. So to turn this into a question, can DHA and the Surgeon General commit to filling civilian positions and completing a new labor market analysis before shifting any additional billets and personnel away from Naval Hospital Bremerton? And can DHA provide me with their current market analysis?
Well, to the last part of the question, sir, yes, we're happy to provide you with an analysis. I'll specifically talk about the OB part of the market analysis. 10 years ago, Bremerton Naval Hospital had about 60 births per month. 2 years ago, it was 33 births per month. This last year, it's been 16 births per month. So can St. Michael's absorb that? The answer is they tell me they can. Now, if they're telling your office they can't, then they're telling us different things. And for that, I apologize. But it's 16 births per month right now. You mentioned the closure of the inpatient ward, the med-surg ward. That's absolutely right. That said, the number of inpatient med-surg admissions was less than 1 per day over the last 2 years. St. Michael's has assured us that they can. In addition, from a backup perspective, because as you know, Madigan is not nearly as close. I think St. Michael's from the gate is about 8.5 miles away. Madigan significantly further away, so we're not primarily relying on Madigan. But Madigan has indicated, in fact, I've talked to the Madigan commander today, that they can absorb whatever St. Michael's can't, whether it's med-surg, whether it's specialty care, or whether it's OB care. It's not a one-time analysis, sir, and if I've indicated that to you or your office in the past, I apologize for that. It is a regular update that we have with HealthNet as the managed care support contractor responsible for integrating the way that we handle care on the peninsula for your beneficiaries, certainly, but even those in other communities outside of your district, we're responsible for them all. If you're getting information that's different than that, I'd welcome it to add it to what we're holding HealthNet to. And I'll turn it over to Admiral Gillingham if he has more to offer.
Thank you, Representative Kilmer. We work very closely with General Place and his team in those areas like your region where there may be difficulties hiring. If there are individual positions that we can backfill, then we do that as required, and that follows from the analysis that the General Place mentioned. I can assure you there have been no divestments of personnel at Naval Hospital Bremerton consistent with the congressional language. We do evaluate each of our NTFs in terms of ability to support platforms for unit training. And so any changes that you may have seen in FY19 or 20 came from some of those reassessments.
Excuse me, gentlemen. Mr. Kilmer, can you hear the answer to your question? I'm having difficulty.
Yeah, it's a little hard if you can speak into the microphone, please.
Seems like you're having some feedback issues.
And now there's no volume from the witnesses.
If there was an additional question,
We were just all very quiet.
Well, let me ask one more question, and I guess it's a bit of a plea. And that is, as decisions are being made regarding potential closures or downsizing of military treatment facilities, my plea is for more robust communication to the impacted communities. I've been on this subcommittee for 6 years. I don't think we've had a hearing related to this subject where I haven't raised concerns about reduction in billets and reductions in services provided at Naval Hospital Bremerton. And yet DHA made no effort to proactively communicate with my office or frankly, any of the outside stakeholders prior to downsizing and closing some of these facilities at Naval Hospital Bremerton. And I'm concerned about that. I think that doesn't leave room for input from outside stakeholders, including service members and beneficiaries and veterans. So my question is, can we count on that going forward?
Yes, sir. You can.
Thanks, Madam Chair. I know I've exhausted my time. I yield back.
Mr. Kilmer, your questions are very important, and you and Mr. Carter have expressed similar concerns, and this committee will work with both of you to follow up on them. Mr. Diaz-Balart and then Ms. Kirkpatrick.
Thank you very much, Madam Chairwoman. I actually thank you, Madam Chairwoman, for stating what you just stated. I think it is important to stay in touch with the members of the subcommittee on issues that are that important. Now, Madam Chairwoman, my specific questions was answered. So I know there are a lot of other questions, so I'll yield back at this time.
Thank you, Mr. Diaz-Balart. Ms. Kirkpatrick.
Thank you, Madam Chair. My first question has to do with COVID preparedness and PPE supply chain. The department, and this is a question for Secretary Mullen, the department is undergoing significant reviews as to how to prepare for and respond to this pandemic and what could be done differently or better in the future. One of the lessons we learned from the pandemic is that much of the life-saving PPE that we depend on, such as face masks, gloves, medical gowns, are made overseas, potentially leaving our supply chains vulnerable to future disruptions like a pandemic. So Secretary Mullen, as things begin to return to normal, what is the department doing to ensure that the basic necessities are available in the event of the next conflict or national emergency?
Thank you, ma'am. That is a very appropriate and timely question. Our office is in the midst of a biodefense posture review with the Assistant Secretary for Nuclear Chem and Bio. Part of that review is looking at the industrial base of PPE. We are just in starting that effort, though the working groups have been underway, and we would be happy to brief you on that outcome when that comes forward. Right now, we are still negotiating roles, responsibilities, and we will be briefing the DepSecDef later this summer. And at that point, we could probably make those, share with you what those efforts are.
Thank you. I really appreciate that. Thank you so much. My next question is for Lieutenant General Dingle, and it has to do with military medical staff. I understand that the Army plans to eliminate nearly 1,500 medical billets in FY23 in favor of lethality billets. It seems that readiness for the next conflict is the driver behind this proposed reduction. But for many soldiers with families, part of them being ready is that they know their family is going to be taken care of. How is the Army balancing medical readiness with the responsibility to care for beneficiaries and Army families?
Ma'am, thank you. Thank you for that question. Again, as I kind of touched on earlier and expand a little further, is we continue to work with DHA on any impact or any change that we do with any military medical billets reduction. As I mentioned, initially 6,900 billets we were initially going to eliminate. That was dropped down to 2,900, and the 1,300 number that you talked about in FY23 is the projected off-ramping. The majority of those billets are empty. Our analysis includes making minimal impact to any healthcare at any facilities that we have targeted for the elimination of those billets. What do I mean? We've done a detailed analysis that the number is not going to close or adversely impact any care that year. And then we will continue to do that assessment each year going into FY24 also, the remainder of the billets. And if it's something that impacts that greatly, then we would have to do some adjustments, whether uniformed personnel working in conjunction with the Defense Health Agency.
Thank you. I appreciate your answer. My final question is regarding the CDMRP and has to do with cancers. So the Defense Health Agency is scheduled to absorb medical R&D efforts that had fallen under Army's Medical Research and Material Command by the end of fiscal year FY22. So Secretary Mullen and General Place, the congressional directed medical research program is an important program to this committee. And as the GAOA has found, a very successfully run program. As medical research, including CDMRP transitions, do you see any changes occurring in the management or structure of the program?
Thank you, ma'am, for that question. The congressionally directed medical research program is vital to our research program at large. And first, let me thank you and the committee for the support of that program every year and the additional dollars that you provide for us to execute. As you have said yourself, we have had excellent outcomes and management of that program, and it will transfer to DHA intact. We do not anticipate any changes to the program. It is in fact successful, and why ruin that?
Thank you very much. My time has expired. I yield back.
Thank you. We'll next go to Mr. Adderhold, followed by Mr. Aguilar.
Thank you, Madam Chair. Thanks all the panel for being here this afternoon. It is my understanding that the DOD is restricted from using funds or military medical treatment facilities to perform abortions, except in the cases of rape or incest or where the life of the mother is endangered. There is a draft Army memo that was recently leaked to the press, and it allows for compassionate reassignment, which would allow commanders to reassign service members out of a state that is considered to have discriminatory laws in regard to various issues, including abortion. My question to you, Acting Secretary Mullen, can you describe the now leaked compassionate reassignment Army memo, and in particular how it would work and who is covered, and of course, particularly in relation to pregnancy and abortion?
Ensuring the health and well-being of our service women and female beneficiaries is a top priority. By law, the department, as you said, does not pay or provide for abortions, except in the case of the life of the mother, rape, or incest. And we do have, as you mentioned, established processes and procedures to ensure access to legally authorized care. I cannot comment on that Army leaked memos. I have not seen it.
Do you know if other services like the Navy, Marines, Air Force, or Space Force are also considering similar policy?
I believe we provide transportation for legally authorized care, regardless of what that care is.
Oh, okay. Well, I certainly would hope that the department isn't considering reassigning soldiers based on their ideological beliefs. And I could only imagine that that could hurt the military's need for good order and discipline. Do you know what the average cost is associated with a permanent change of station for a soldier, either under compassionate care or otherwise?
I cannot answer that question. I have to take that for the record.
Okay, if you could please let us know for the record, I would appreciate it. Thank you. I yield back.
Thank you, Mr. Adderholt. And our women, based on where they are stationed, should not be subject to not being able to exert their full rights for health care. Mr. Aguilar.
Thank you, Madam Chair. This question, I'll start with Acting Assistant Secretary Mullen and Lieutenant General Place. Last month, we were pleased to see the DoD published an equity action plan following President Biden's executive order to advance racial equity and support for underserved communities through the federal government. Can you share the health barriers that underserved military members and their families have faced, and what specifically this action plan, how specifically this action plan can help address those?
Undersecretary Cisneros, who is my boss, has made racial equity and disparities one of his top priorities. I heard him speak about that at the Uniformed Services University graduation last week. As far as our organization, as you know, our healthcare system because it is accessible and almost is free to active duty service members and their families, our actual outcomes are better than the average in the United States, particularly for our Black families. We're very proud of this. We have other areas that we do need to work on, but I would say that we are in a good place.
If I could add to that, sir, you asked specifically about now the execution of it. It's twofold. First, as Acting Assistant Secretary Mullen said, the outcomes are very, very close, but they're still not the same. And there's a belief among some of our communities that the care that they will receive, even though they have access to it, will somehow be different. So part of that now, our responsibility is to get into that decision space. Why do they think that? And where can we target information to either help them understand or show them what they need to see such that they will access it? They already have that available to access it, but in some places they're not. So the research that we're now doing and the databases that we're using are getting to the exact question that you're asking to answer that question.
Thank you. I appreciate that. Shifting gears a little bit, Secretary, wanted to ask, follow up on Mr. Calvert's question related to mental health. He talked specifically about wait times within TRICARE But how can Congress support DoD's goal to lower patients' costs specifically for mental health services? So we should treat this in two areas, access, obviously, and wait times, but cost associated with this and the role that telehealth services plays. Can you talk a little bit about that?
Well, there are small co-pays for active duty family members who are accessing the mental health within the managed care support contract. It is low, but there are some, costs associated with that. And as we stated earlier, the wait times there are a little longer, though I believe they are much shorter than those of our civilian counterparts. As for wait times within our system, I think we commented on that we are, striving very hard to add providers to the system. We actually have incentives and bonus pays to try and recruit additional providers into our system. So we do appreciate what you're doing for us. And General Place, do you have more to comment?
Yes, sir. I mean, that's a fundamentally important question. Telemedicine, I believe, has multiple uses, but in particular in behavioral health, in that most of what we do as clinicians involves some sort of physical exam. Now, that's not to say that it's not important in behavioral health, but it is not nearly as important. What's happening in the thought processes is the most important part. So really leveraging the capabilities in telebehavioral health. We're doing it. We need to do more of it. Specifically to the Congress, though, there are some limitations, not just for us, but for the entire community on what's the requirement for the location of the patient, what's the requirement for the location of the counselor, the psychiatrist, the psychologist, et cetera. They don't always match. And so there are significant challenges using telemedicine to do that. Further, the TRICARE program, of course, is capped at Medicare and Medicare rates. And when we go to the network, when we use Medicare or our managed care support contractors, of course, they take their pay out of that as well. So all that we're using in the network is Medicare, Medicaid minus. And so it limits in some locations the number of practices that are willing to be part of our network just because how little we pay for behavioral health services. Those are things for potential consideration.
So I do believe we get to pay our providers up to 125% of CMAQ rate in order to recruit some mental health providers. We have been authorized for that.
Appreciate the answers. Thank you both. I yield back, Madam Chair.
Thank you. Mr. Christ will be joining us, and there he is. Mr. Christ, I call on you. Before I do, members, we would have time for a limited second round of questions. So far, only one member has responded that they have a second question. Anyone else who has a second question, please put it in the chat so that I know. Other than that, you might not be called upon, and that would make me feel bad if you wanted to ask a second question I didn't know. Mr. Christ.
Thank you very much, Madam Chair. I appreciate it. In January 2020, Iran launched 11 ballistic missiles at Al Said Air Base in Iraq. While we avoided immediate loss of life, over 100 service members have since been diagnosed with traumatic brain injury. I am concerned because even though the bunkers mostly held and they had ample warning to take shelter, so many service members were diagnosed with brain injuries. Some of them were severe. As General Milley said at the time, the troops in the attack will need to be monitored for the rest of their lives. If we are making investments to counter Russia and China, we also need to protect our service members against powerful weapon systems, including ballistic missiles. What are we doing to better protect service members from ballistic missiles and more advanced weaponry? Whoever would like to answer.
Okay. All right. Let me just start up with this. In terms of traumatic brain injuries, there is probably nobody better for the actual treatment, diagnosis, treatment, and follow on than the Department of Defense. We've invested hundreds of millions of dollars in traumatic brain injury research and treatment, and we have a very warm handoff to the VA, which then subsequently takes care of our men and women.
Right.
The research that we have also done to that to try and do preventive is also underway. And I imagine that, though this is outside the scope of probably the people at this table, the kind of preventive gear and armor are I'm certain we are investing in that, and I actually do know that, although I've not seen that myself.
And then Representative
Well, thank you so much.
Just a small piece, you know, and most
Please
from our
identify your-
project Convergence 21 is classified, but the Army, through Army Futures Command, is working on several systems to help defend, you know, soldiers or troops on the ground against that type of missiles. And that's under our Army Futures Command and Project 21 Convergence, Project Convergence.
And Representative Christ, I would just add within the Navy, the Office of Naval Research is doing a significant amount of work in terms of understanding chronic exposures. So particularly for our special operators and those who operate underwater, understanding the long-term impact to the blast exposure they receive. So I can assure you there's quite a bit of work going on in that area.
I'd also point out that the Army Institute of Surgical Research, which I've recently had the opportunity to tour, is doing some amazing cutting edge combat casualty care research and deployment of new items and protective measures.
Thank you very much. In this same hearing 3 years ago, I asked about the ban on transgender service members. I'm still deeply disappointed that officials minimized the service of these brave patriots in front of this committee. However, I was proud of the leadership shown by the President and Secretary Austin in reversing that misguided policy just over 1 year ago. Can you all please provide an update on how that reversal has been implemented in the services and across the department? And thank you very much.
So I'll have to take that for record to give you the exact numbers and where we were and where we are right now.
And sir, this is General Miller from the Air Force.
Yes, sir.
All airmen, guardians that are going through a transition process are seen in a single unit for us down in San Antonio at the CMU, the Transgender Health Medical Evaluation Unit. That continues to be a successful single point of contact. Present numbers for them, they have actually have 374 airmen that are in the process, of which 100 have transitioned, and an additional 33 have had surgery based upon their unique needs and requests. So that is something that we feel is very successful, and irrespective of what base an airman may be from, having that single point of contact allows for consistency and then ongoing follow-up after they are, if they so desire, are there for generally about a week of time to meet with the specialist.
Thank you very much, General Miller. I see my time is running out, and I will yield back, and thank you, Madam Chair, very much.
Thank you. Mr. Calvert, because we're trying to do this live stream and people have been on and off, I'm just going to call on members for a second question. And I'll let people think about whether or not they have one, and I'll do a quick one. And I know Mr. Kilmer for sure wants to ask one. So I want to talk about baby formula for a moment, which is not something the Department of Defense and most of you, are up thinking about. But we have a lot of service members and their families that are here in the States dealing with the baby formula issue. I'd be interested in knowing what you've done to reach out, especially with all the misinformation on social media. And, many of these families, when they're traveling, they're far away from friends and family and people that, would normally be there to help and support them on an issue like this, maybe even, checking stores routinely shelves to get the formula. What have you done to make sure that families are receiving the right information at the right time, and anything that you've done to assist our families as I said, they're sometimes often far away from home, experiencing a birth or, kind of on their own. So what's been the department's health response on this?
Ma'am, Ron Place from the Defense Health Agency, if I could. So multifactorial, the first of which is correcting incorrect or misinformation. For example, there's a social media site that said TRICARE has free formula, which we do, but for very specific medical conditions, to have that provided as if it's medication. In addition, we've partnered with the DECA, the commissaries, and have looked at what do we have available on our commissary shelves and what are the requirements in those communities. We have the ability through the Defense Logistics Agency to balance formula availability. When it comes to formula availability in our medical treatment facilities, or in particular for those that have obstetric services, we don't have an issue with it. From the relationship that we have from the commissary system, we don't have a significant issue on our shelves. The question that you're asking, though, is what happens when they PCS, or what happens when they go on vacation? The information that's coming from our installation leaders, as well as our local medical leaders, is plan ahead. We are blessed to not have those issues in our community, so plan ahead. And if you're going to be going somewhere, make sure that you utilize your commissary benefits before you travel so that you have it everywhere, as opposed to relying on what may not be available in a particular community. That's, in general, the depth and breadth of what we're doing.
Thank you. Mr. Calvert?
The only last issue I'd like to talk about is, Ms. Mullen, I'm concerned about the trend, the worsening trend of facilities, sustainment, restoration, modernization. That account is obviously of need of help. I understand there's already about a $3.6 billion gap in your FSRM needs, which is now projected to grow another 500 million if this request is supported as is. So I'd like you address those needs. And I understand that some of these costs may be a result of maintaining empty buildings. So what do we need to do as far as a way of authorities to divest yourself of these buildings? Is there any assistance we can do? I don't think, I'm hopeful that doesn't necessitate some kind of a BRAC or that we can't do this administratively or through the appropriations process. And is DOD and VA trying to leverage each other's facilities when possible to increase efficiency and reduce costs?
We share your concern about that backlog as well. The current inflation rate hasn't helped that either on that end. The backlog is about, I believe, 500 million and growing. As you know, over the years, as our budget has been tightened up, unfortunately, it is one of the places where we've had to take, as one we could say, for efficiencies of reprogramming, that has where we found the dollars. Our facilities and building them are extensive and are multi-year and quite expensive. As for what we would need to get rid of empty facilities, that part I don't know. I'll ask if General Place can comment on that.
Sir, all that I'll add is three things. First, thanks to the committee for adding $78 million to our FSRM budget for this year. Certainly, it'll go to some of that backlog. I am equally tracking the 3.6 billion in arrears in costs. Second thing that we're doing, or first thing we're doing, second comment, is bringing them all into the department's program. It's called Builder, where we evaluate every single structure and their capabilities to include the critical infrastructure. The advantages that we have is to be able to look at all bits of critical infrastructure on every building, on every installation, at every week. And so while the delta is growing, the critical infrastructure has not changed. It is always cared for. It is always updated. We've always had the resources for that. Now, what that might mean in the out years may be significant, in large part because of the investment of the Congress over the last 20 to 25 years, in particular, when Operation Enduring Freedom, Operation Iraqi Freedom first started, with an investment in multiple new facilities. They're all at about the same age, which means as they grow older, the investments, instead of being flat, tend to go in a sinusate fashion, and that will be a challenge for us. What you've addressed with the last part of your question, though, relationship between the DOD and VA is significant. I think you're aware of the Air Commission that the VA has done, the Asset and Infrastructure Review. We are very tightly integrated with them to the potential to utilize our buildings for their use or their buildings for our use to drive down the requirements for medical infrastructure between the VA and the Department of Defense, meeting those effectiveness of the use of the buildings that we have. We are not looking for a medical BRAC, nor do we see one coming.
I would hope you could do that, think out of the box a little bit. If we have these facilities that you could leverage both for VA and normal use, that makes perfect business sense. And if you need any authorities or assistance, I'm sure the chair and myself would be happy to help in any way we can. It just makes perfect sense.
Thank you for that.
Thank you. I yield back.
I'm with you, Mr. Calvert. It appears that Mr. Listenberger left, so I would next go to Mr. Kilmer and then to Mr. Carter if you have a second question. And these are 3-minute rounds. Mr. Kilmer.
Thanks, Madam Chair. I'll be brief. General Place, I know DHA will increasingly rely on civilian personnel to backfill some of these military billets. Unfortunately, military treatment facilities are already struggling to hire for open positions, given some of the nationwide shortages of healthcare workers and challenges in terms of providing competitive wages and some of the long hiring times, not to mention COVID's impact on the entire healthcare sector. Certainly, the military health system has seen folks leaving for higher pay and more flexibility and more stable work environments at civilian hospitals. These reductions are particularly acute among women's healthcare specialists who've not been prioritized by the military health system. So given these challenges, does DHA's budget reflect the need for additional civilian hiring incentives to make up for uniform billet reductions? And if so, can you just explain how so? And if not, what else do you need from this committee?
The environment that you're describing is an accurate reflection of the environment that we're facing. To project what authorities we might need or what incentives might be helpful from a monetary or other, I think is a great one. I think it'd be better for us, instead of answering in a minute, to provide you with a really in-depth answer. So if I could, I'll take that specific part for the record. But the other things that we are doing is talking with our staff about the non-monetized benefits of working in our system, the privilege that we have to take care of America's sons and daughters, the leadership opportunities and leadership growth that we have for both our uniformed and civilian staff, the ability to utilize their GS status to move from place to place. Not everybody wants to, but some do. And how do we leverage that ability for those who want to be able to move around the country? Those are just some of the examples, but there's much more that I could get into in a formal response.
Can I just ask, I am curious what you need, but is what you need reflected in the budget submission?
Sir, it's a complicated question, as you know. In general, I think the answer to that is yes.
Okay. Thanks, Madam Chair. I yield back.
Thank you. Mr. Carter, did you have a second question?
Yeah, a little bit. This may be scuttlebutt, but is the Navy deliberately not filling medical positions because the decision has been to hold off for approval to shed those billets in favor of lethality purposes? Who has made or who would make the decision to begin suppressing billets?
Yes, thank you, Representative Carter. No, there has been no divestment of any of our Navy medical billets. We are actively reanalyzing the requirement for our medical manpower, recognizing the guidance from Congress, as well as the realities of what we've learned from COVID, Homeland Defense discommission, what we've learned in the fleet about the ability to respond to a pandemic and keep the fleet out forward. So, sir, I can assure you that analysis is ongoing. There has been no billet suppression. We are strictly following the requirements of the NDAA.
The other thing I want to point out is it's been reported to me that there are concerns at locations like in Japan and Korea with respect to the care of our service members. What risk has been are to the beneficiaries, are beneficiaries going to be faced with, and what about service members? I guess Secretary or Lieutenant General Clay.
Yeah, I'm sorry, I missed the last part, but specific to Japan, sir, I was actually out there the last 2 weeks, meeting with leaders, meeting with communities, 9 different town halls and 7 different installations to get some of that. There's really 2 major factor functions. The first of which is the Japanese health system is different than the American health system. A great example is they don't follow Impala law. So you could show up in the emergency department and they can refuse to see you, which is so much different than what we're used to. The second is most of the installations that we have a lot of them, but most of them are relatively small. And so in order to have enough workload to keep a particular specialist busy, as well as to keep their skills, it's hard to do that. And so the things that we're collectively doing between the service surgeons and myself is find ways to leverage telemedicine, telespecialty health, find ways to leverage peer-to-peer advisors, find ways to leverage where we can consolidate particular services and then utilize ground transport or air transport that the military services have available and get the right person, uniformed or family member, to the right location at the right time for care inside of our MTFs in Japan, as an example.
Thank you, Madam Chairman. Yield back.
Mr. Calvert, we're ready to close. Anything you'd like to say before I wrap her up?
I appreciate the hearing and look forward to working with you to make sure we get the assistance to our men and women in the military for their health care. And thank you for having us. Thank the panel.
Thank you. Thank you. I think you asked some great questions and I look forward to working with you on them. I'm going to comment on the Japanese healthcare system. I can't speak for every incident, but having broken my wrist in Japan, the care was, I was literally a foreign walk-in. The care was outstanding. And even the one prescription that I was given that can't be filled here in the United States, my surgeon here, I ended up having to have surgery, was amazed and disappointed that we didn't have that type of medicine available here in the United States. So we're going to follow up on that. It might be an outlier, but having to do a cold walk-in for a broken wrist, no questions asked, just being taken care of. And they did not know I was a member of Congress. They just knew I was somebody who was in pain and hurt. So I want to follow up on that because my experience was totally different. I want to thank you for all the questions and the time and attention and the concerns that you've expressed as subcommittee members with the panelists. We look forward to hearing back. But before I get into my 2 questions for the record, I just want to take a second, I think, to reflect on all the work that you did during COVID. We appreciate it. Our nation appreciates it. And right now we appreciate the work that you're doing at Brook in Texas to help us with a tragedy of tremendous proportion, watching innocent children being gunned down with assault weapons. Congress needs to act to do something on that. So thank you for taking care of them. We know that they are in good hands. I have 2 questions that I'm going to be submitting for the record. One has to do with the Chaplain Corps and a little bit about what I said earlier with mental health. But I'd like to understand how integrated we are with the Chaplain Corps, respective to their roles in mental health support. I've spoken to several chaplains over the last couple of years, and just one recently on Saturday. And they stand ready to help, but the way that they're deployed and brought in and used, I think is something I like to better understand to see how we can have that be a multiplying force, especially when it comes to mental health. So how integrated they are in suicide prevention programs, how often you talk to them, if you're able to just have a dialogue to kind of pick up on the health of things that are going on, respecting everybody's healthcare privacy and religious privacy as well. I'm also going to be asking a question for the record on the medical, chemical, radiology, and nuclear prophylaxis and what's going on with that. I've been approached by two groups that want to be more engaged in educating me on that. And if I'm going to be educated by them, I want to be educated by you as well. So I'm going to have some questions for the record on that. So with that, once again, thank you for your service. We thank all of those who serve alongside of you, both in uniform and in civilian clothes. And with that, that will conclude today's hearing adjourned.